Hello, this is a slide presentation on health costing. When you talk about health costing of a country, we have to see on the basis of economy, either economic context. As we know, we have um, graduated from least developed country status to developing country in 2023, December 2023. We also on GDP, on gross domestic product basis. On the first graph, we can see there is an developing, improving GDP, and there is a slight dip in 2020, and after that, we have again an increase of our GDP. Right now, it's around $3,600, which classify our country in a low middle income criteria. So basically, we have in 2006 only um, we have been promoted from a low income country to lower middle income country. And the second graph also shows the comparison between the countries, and we can see Bhutan is doing quite well in basis of per capita income, and compared to other South Asian countries, we are quite in the middle, with Maldives being ahead of us. And when we see compare it with the developed countries like Japan, UK, we can see we are further behind in terms of gross domestic product. Health in Bhutan, we have achieved many goals, overcoming challenges. Like we have seen drastic improvements in indicators like maternal mortality rate and neonatal mortality rate. And although we have seen so many development and achievement of goals, we do have remaining challenges in our country when it comes to health, and we are also seeing new challenges emerging. Like in Bhutan, we see 1 of 5 children under age 5 are stunted, and we have high prevalence of anemia among children, adolescent girls, and women of reproductive age. There is emerging double burden of malnutrition, which includes both extremes. Either we can go with undernutrition or overnutrition. There is a prominent socio-economic and geographic disparities. Like in Bhutan, health facilities, National Referral Center is in the west, so it is easier for people to avail specialist services. And also overall care, health indicators, like we have stunting rates, which seems to be higher in the eastern region and also in the rural region, in the pocket areas of Bhutan. There is a rising aging and rising dependency ratio, which means we have a rising population of elderly, and we are seeing decline in the birth rate, which means there is a kind of replacement rate is poor. So we the elderly care will be compromised, and we have also rapid epidemiological transition, greater complexity and chronic conditions. Human resource, like we see many Bhutanese moving abroad for better futures, so we do have shortage of human resource, and that includes the specialists. Although Bhutan, and we see in Bhutan, although they we have we have a proper primary health care in the country, which is spread across the districts. The people tend to bypass that services in order to get the specialized services in the National Referral Center and the regional referral hospitals. So they tend to underutilize the primary healthcare services which are available near their home, and they tend to use the referral health services in the referral centers, which proceeds to become a burden in the national referral centers. And due to that, as they bypass the primary healthcare services, we see a lot of out of pockets OOP spending in transport related things. And although Bhutan has all specialized care in the National Referral Center, we do have to refer patients for further management and for advanced care to hospitals which are mostly to India. And as Bhutan has stepped into a developing country from a least kind of developed country status, we have a decline in external financing. Sustainability of health financing is a key concern in light of existing and emerging challenges related to aging, climate change, and pandemic preparedness. So, coming to the Universal Health Coverage (UHC), it is one of the United Nations 2030 Sustainable Development Goals, which is about ensuring that all people can use the promotive, preventive, curative, and rehabilitative and palliative health services they need of sufficient quality to be effective, while also ensuring the use of the services does not expose the user to financial hardships. So if you see the figure is a cube, and let's say the vertical thing is y-axis, and the base includes x and z. So we can see this whole cube represents a total health expenditure, and the blue box indicating representing prepaid / pooled funds, which means it can include insurance and government agency funds. So what happens is that the health expenditure is the total health expenditure of a country is the expenditure spent by the government and the insurance company, plus the out of pocket spending of the population. So what we can do to have a universal health coverage, so we can cover more cost to reduce out of pocket spending. So that y-axis, the direct cost proportion of the cost covered, we can narrow down that spending, so we will be able to have more universal health coverage. Like in the sentence, we can see UHC can be thought of as a direction, not necessarily a destination, because to have a perfect UHC is impossible, near to impossible. And we can see a population coverage. So UHC includes covering the out-of-pocket spending, and also we have to cover as much as the population in the country. So right now we can see here the blue box showing that certain amount of population is being covered, the health services, but there are gaps, so we have to cover that gaps. And also if the healthcare reaches the population, the types of services, the other services like specialized services, is there is a gaps of availability of specialized services in the population, so we can provide that services, like in our healthcare we can do surgical camps and clinics. So with this thing we'll be able to achieve that goal of having all the people which who can use the promotive, preventive, curative, rehabilitative, and palliative health services they need, and also ensuring it to be having quality and it doesn't harm the population who is using it. After we understand what is universal health coverage, this slide shows about health financing in the context of UHC. So we have building blocks like service delivery, health financing, and governance for universal health coverage. And the outputs are basically we have service, access, readiness, quality, safety, financial resources which gets pooled, crisis readiness, and we have outcomes like effective service coverage. We have universal health coverage, and we have financial risk protection and risk factor mitigation. So what does universal health coverage do? Universal health coverage with proper health financing have leads to improved health status. We have improved financial well-being, and we have improved welfare. So for universal health coverage, we have a sustainable developmental goals target, which is to achieve universal health coverage. We have indicators like given by World Health Organization, which includes coverage of essential health services, which are reproductive, maternal, newborn, child, infectious disease, non-communicable disease, service capacity and access, and we have another indicators classified as financial hardship when seeking care, which includes the calculation of proportion of out-of-pocket spending as a share of household budget. This graph is just showing how out of proportion of out-of-pocket expenditure, which can make a population suffer if the out-of-pocket expenditure is less than 10%. There is no financial hardship, and if you have more than 10% and it's pushing you into poverty because your proportion of your out-of-pocket expenditure for your health services is higher, then it can lead to financial hardship, which includes poverty, and even the people who spend more than 10% but not push into poverty are considered to being having financial hardship. So in the context of universal health coverage, when it comes to building blocks, we'll deep dive into health financing. So what is health financing? A narrow concept of health financing can be health financing as mobilizing of financial resources. To have a broader concept of health financing, this slide shows how health financing helps in providing health services. So basically, there is a resource mobilization. Then we see which a population are at the risk, and we can do a risk pooling. Then after that, we can have purchasing of needed equipments for the services, and we can also allocate resources, and at last basically providing services to the required population. So to know more about health financing, to elaborate on the resource mobilization, risk pooling, resource allocation, and purchasing of the relevant equipments, we can see the slide in the ideally section. So health financing ideally raise sufficient and sustainable revenues in an efficient and equitable manner from compulsory prepaid sources. And risk pooling will pool health risks of efficiently and equitably and maximize rate distributive capacity by reducing fragmentation. Define explicit benefits package commensurate with revenues and services delivery capacity, and have mechanism to expand over time. To assure allocation of resources and purchasing of health services in an equitable as well as technical and allocative of efficient manner, moving away from rigid and open-ended provider payment system as needed. So basically it's saying that the amount of health financing means the country will have certain spending on health, but they cannot spend their way to universal health coverage, as how where the money comes from and how the resources are allocated and utilized, they are important when it comes to health financing. So when it comes to health financing, we talk about resource mobilization, and there are modalities for that, and each modality associated with different mechanisms for resource mobilization. We have prepayment and risk pooling, and we have what we say prepaid pooled funds. We have prepaid pooled funds, and which includes the country's taxation, general taxation. We have social health insurance, compulsory private insurance, voluntary private insurance, and external financing, which make up the prepaid pooled funds. And if we can remember the previous slide, which had universal health coverage, we had prepaid pooled funds which finance our health services in our country, and the one which the health expenditure coverage is not included is the out-of-pocket expenditure, which is spent by the general population. When it comes to financing for universal health coverage, there are different types of prepaid pools in the country, and different countries have different kinds of prepaid pools. Out of that, public financing is the key for universal health coverage. So different types of prepaid pools starts with public financing, which includes two types, which are general taxation, which is mandatory payment of general taxes, and out of that income taxes, certain portion is given for health, and it usually covers the entire population. Another type is social health insurance, that is also mandatory, and it is wage-based payroll deduction, with general taxation subsidizing the contributions of people who cannot afford to prepay. So it's also a similar kind of thing, and contribution linked to entitlement and traditional covers formal sector workers, sometimes their families, extended to others with government subsidization of contributions. The other type is compulsory health insurance, which is kind of mandatory, and purchase a private health insurance with government subsidizing premiums of people who cannot afford to prepay, which is used in countries like Switzerland, Netherlands, and United States of America. There is a type called voluntary health insurance, which is the name suggests voluntary, and the premiums rarely vary with income, but vary with risk, including age. More is charged for people deemed at higher risk of incurring health costs, and this covers people who choose to purchase it, and also it often used to complement or supplement other forms of coverage. So this is in the United Kingdom from the National Health Service, also known as NHS in United Kingdom. And the form of prepaid pooling is the general taxation. And out of the taxation, there's certain portion which is utilized in health, and the entitlement is the entire population. So it was implemented in 1948, with resources raised via general taxation to deliver services via a network of public providers. So the strengths of general taxation is there is a broad revenue, and it pools risk for entire population. It covers the financial burden of financing health can be spread across the entire population, and it can be a progressive source of financing. Weaknesses is where it is problematic in countries which do not give preference to health. For example, they give preference to military services. So this kind of model will be challenging in those countries, and it will be potential unstable source due to annual budget process. It is susceptible to weakness because of public financial management systems, and because corruption is rampant everywhere, and because of poverty, large informal share of economy and capacity constraints limit revenue generating capacity in many developing countries. This is the best kind of model, and it is used in countries like Cuba, Sweden, Norway, and best example is our country, Bhutan. Second type of public financing is the social health insurance, which was actually started in 1883 with the passage of social health insurance law for laborers by Germany's Chancellor Bismarck. So typically its pooling is done by quasi agency that purchases health services from different providers on behalf of those who are entitled to coverage. In the same way as the general taxation, the strengths of social health insurance is it is an additional revenue source which benefits tax and contributions from employers. It removes health financing from annual general government appropriation processes, which was the weakness in general taxation. It facilitates organizational change and can enhance transparency and accountability, which is also the weakness of general taxation. Weaknesses are it's difficult to mandate and collect contribution in countries with large levels of informality and self-employed workers. Also, it often requires extensive subsidization from general taxation. It also includes mandatory payroll contribution, which can increase labor cost, reduce competitiveness, and contribute to informality. Examples countries are like Japan, France, Germany, and Bosnia. Since we have mentioned in previous slide that public financing is the key to universal health coverage, which includes both general taxation and social health insurance, there have been recent blurring of lines between the two, because a country is not using one method, is using both types to improve the financing in the health. Like many elements of social health insurance, purchaser provider slate, inclusion of private providers can have been institutionalized even in countries with general taxation. So in some countries, general taxation is augmented with earmarked taxes to contribute towards health, like in UK, India, Bhutan, and Australia. More and more countries with social health insurance system co-finance via general taxation. And differences between general taxation and social health insurance systems increasingly blurred as countries move towards diversified public revenue sources financing for health. This figure shows how universal health coverage can be achieved via different types of prepaid pools, which includes the general taxation, social health insurance funds, and both. Like in the previous slide, we mentioned that there is a recent blurring of prepaid pools funding of health between general taxation and social health insurance fund. Global health financing landscape graph, and it includes the per capita total health expenditure. This is in year 2022, and what we have is per capita total health expenditure Britney's is US dollars $155 in that year 2022, which is actually more than Sri Lanka, Cambodia. If we are including South Asia like India, we are spending more than India, Sri Lanka, Bangladesh, Pakistan. I think only Maldives is seen having more per capita total health expenditure than us, which is near $1,000. And interestingly, we have total health expenditure of GDP in 2022, which is 4.4% of GDP is used in health expenditure, and that is also we have more than Sri Lanka and India, Pakistan, and Bangladesh, which actually is good. And interestingly, we see Nepal more than us, more than 5% it seems. And to highlight on Maldives, the expenditure is more in South Asian region. Maldives is has the highest total health expenditure share of GDP. With universal health coverage and health financing, there is always quality linked with it. So the upcoming slides will be discussing about efficiency, which will lead to good quality, and the component of quality, it is always there when you talk about universal health coverage. So what is meant by efficiency? So the component of healthcare services usually consists of government, regulatory entity with resource suppliers, financing agencies, and health providers, which will provide health services to the consumers. So there is always it consists of health status and citizen satisfaction and risk protection. So in short form, in summary, consumers want value for money, what is fit for purpose. Deep diving into it, the link between health, financing, and quality. So the quality usually is the health services should consist of, as discussed before, health status should be good, The consumer's health status should be good, and there should be citizen satisfaction, and they should value the services they get. And there should be a risk protection where citizens should not be spending their money and they should not have any financial risk. So this should be the goal of having a quality health services. So if you want to define quality, Evidis Tony Vidian in 1966, his model consists of these three things: structure, process, and outcome. Structure refers to physical and organizational characteristics where healthcare occurs. Process, where they focus on the care delivered to patients, example services, diagnostics, or treatments. And outcome, effect of healthcare on the stages of patient and populations. So if you want to have a high quality health system, what it should consist of? So basically it should be driven by the values of putting people first, acuity, efficiency, and resilience. And for people, the process of care, quality impacts, and for learning and improvement, the population health needs and expectations should be met. And there should be good governance, the platform's accessibility and organization care should be there. A number of HR human resources should be adequate, and there should be enough adequate equipments, medicines, and data to have a high quality health system. So what does the health financing come into this part where quality should be good? So we know that health financing is one important mechanism for ensuring quality. To have a quality healthcare services, there should be standards. We have to set standards, we have to monitor, we have to assure improvement. So out of these three, the assure improvement is we can improve on it by having a good paying system, good health financing. So how can a health financing mechanisms improve the quality? How we can align payments with health outcomes rather than service volume, incentivizing providers to follow best practices and improve patient satisfaction, and encouraging cost-effective high-value care while preventing unnecessary procedures. Coming to the strategic purchasing, like we said, we have to pay for value, not just volume. So examples of strategic purchasing are performance-based financing. So hospital clinics, they receive incentives based on quality indicators, and also result-based financing. Payments try to achieve health targets, like the WHO indicators like maternal mortality reduction, immunization rates. So these are the provider payment reforms aligning incentives with quality. So these are the payment models to reward quality and efficiency. First is capitation, which is fixed per patient payment, which encourages preventive care, as the physician has a certain amount of patients and his payment is fixed according to the numbers. And diagnosis related groups, they have fixed payments based on diagnosis. Bundle payments, they are single payment for all services related to a condition like hip replacement. Global budgets means fixed annual provider budgets to cover population health needs. It is to promote efficiency but needs quality safeguards. Quality should be there in public-private partnerships, as government engages with private providers, making quality assurance in this partnership critical. So whether it's public or private, the target population should have good health status and good citizen satisfaction with risk protection. So to maintain quality in public-private partnerships, there should be contracts with clear quality benchmarks, regular monitoring, performance audits, incentives and penalties tied to patient safety and treatment outcomes. To have a good quality in the healthcare services, the policy makers also has leverage in this to provide good quality health services. So what can they do is to align health financing with quality improvement. They can shift to value-based models, strategic purchasing to incentivize quality, align financial incentives with patient outcomes, not just service volume, strengthen accountability and monitoring, leverage data, accountability and technology for quality-driven financing, integrate national quality indicators into financing decisions. Our next topic is about healthcare costing analysis, which is a crucial tool for understanding financial requirements of delivering healthcare services. Healthcare in our country is primarily government funded. Cost analysis helps policymakers make informed decisions on resource allocation, efficiency improvements, and financial sustainability. So, importance of healthcare costing is relevant in our country also, because it is essential for to have a healthcare cost analysis. It is essential to have financial sustainability, enhancing efficiency, informing policy decisions, encouraging cost awareness, and improving healthcare planning. The objectives of the study is to have a good to generate evidence for informed decision making, to enhance the efficiency and sustainability of Bhutan's healthcare system, to raise awareness among policymakers, healthcare administrators, and researchers regarding cost structures and expenditure trends, and to provide the Ministry of Health with a clear understanding of the cost of delivering healthcare services at the different facility levels. So these are the costing approaches in healthcare. Understanding different costing methods is essential for resource allocation and financial planning. So these are the costing approaches. Top-down, there is a top-down costing approach where one allocates total expenditures to different services based on predetermined ratios. It provides a macro level overview but lacks service level granularity. Bottom-up costing estimates the cost per service by summing up direct and indirect cost, offers more precise service level data but requires detailed cost tracking. We have activity-based costing, ABC, assigns cost based on the actual resources consumed by specific healthcare services, leading to more accurate cost distribution. So we have marginal costing, which evaluates the additional cost incurred when treating one more patient, useful for assessing the impact of scaling up services. So the methodology in the study was used the top-down costing approach, ensuring consistency with 2010 study. Costs were allocated based on weighted criteria reflecting service provision, patient volume, and facility type. Data sources including annual financial statement, patient record, and all the records, extra records. So the study covered all type of healthcare facilities, ensuring comprehensive representation. 12 healthcare facilities were analyzed, including National Referral Hospital, District Hospital, and primary healthcare centers. The study covered a substantial portion of national healthcare activity. Limitation of a study, as previously discussed, top-down approach usually overlooks micro-level variations. Uniform facility model failed to capture local differences. Service quality issues, there was no evaluation of healthcare outcomes. Service quality was not assessed. Missing cost details, record estimation. COVID-19 restriction was there, hindered field verification. Data challenges were there. Smaller facility impacted by volume sensitivity. Patient volume affects unit cost calculation, and cost calculation sensitivities were the limitation in this healthcare costing study. So how the results can be used, like previously discussed, healthcare costing can be used for to plan and to create awareness, and to have proper resource allocation. So there will be planning and budget allocation for disease burden analysis, service payment introduction, result-based financing and efficiency, improvement in referral system, and health technology assessments. So these are the key takeaways of this healthcare costing study. Healthcare costs in Bhutan have increased significantly since 2010, requiring strategic planning for financial sustainability. Higher level hospitals are significantly more expensive, reinforce the need for improved patient referral mechanism. Primary healthcare expansion is a cost-effective strategy, reducing the burden on referral hospital and lowering system-wide cost. Costing analysis is critical for data-driven policy decisions, guiding resource allocation and financial planning.